I'd first like to start by introducing myself as well as the other speakers. For those of you who do not know me, my name is Micah Lay. I am a research analyst with the CARE Registry at UCSF, and I've been with CARE since its launch 2 years ago. And I'm very grateful for the opportunities that I've gained and community connections that I've gained through my involvement with CARE. I'm also very passionate about community health and reducing health disparities in my community. Our next speaker is Dr. Joyce Javier. She is an associate professor of clinical pediatrics and preventative medicine at the Children's Hospital, Los Angeles, Keck School of Medicine at University of Southern California. She received her Bachelor's of Science from UCLA and MD from UC Irvine, and has also completed her residency training in pediatrics and postdoctoral fellowship at the General Academic Pediatrics at Stanford University. She also specializes in optimizing Filipino American youth health, and her research focuses on reducing mental health stigma and works towards preventing suicide and depression among young Filipinos. Our next speaker is Arceli D. Antonio, MSRN. She is a retired nurse after serving in nursing for 50 years. She received her master's in nursing at UCSF in 1972, and she primarily worked in long-term care and served in multiple positions of director of nursing, nursing consultant, professional services consultant, supervising different disciplines, vice president of operations, supervising 7 to 10 facilities. And her last employment was at the Channing House, a continuing care retirement community, serving as Director of Health Services. She is currently involved with the Philippine Nurses Association of America Foundation and Philippine Nurses Association of Northern California, and involved in church activities. Our final speaker is Dr. Jessica De Leon. She is a behavioral neurologist and assistant professor of neurology at UCSF Memory and Aging Center. She received her undergraduate degree in neuroscience and Spanish at Johns Hopkins University and obtained her MD with thesis degree at UCSF. In her clinical time, she cares for patients with Alzheimer's disease and related dementia as an attending physician at UCSF Memory and Aging Center and at the Zuckerberg San Francisco General Hospital. Her research focuses on how bilingualism, language typology, and genetics affect symptoms, neuroimaging, and progression of neurodegenerative disorders, including Alzheimer's disease, frontotemporal dementia, and primary progressive aphasia. I'd also like to touch on our presentation agenda. So we'll first begin by reviewing Alzheimer's disease related dementias and Filipino caregiving data, then go on to describing the CARE Registry, goal to help address research gap, and why Filipinos should participate in research, then a Filipino perspective on Alzheimer care, then addressing research needs for Filipinos. Then we will conclude with our Q&A session. So please stay to the end and feel free to give us your questions, and we'll also finish with our gift card raffle. So stay to the end as you'll all be entered into a gift card raffle. I'd also like to acknowledge that October is Filipino American History Month. This year's theme that we are very proud to celebrate is celebrating our history and legacies. We're proud to acknowledge 50 years of Filipino American Studies, 40 years of Filipino American National Historical Society, and 30 years of the establishment of Filipino American History Month in the United States. We're so proud to celebrate Filipino Americans' history, cultures, and accomplishments in this country. Now we will start with our CARE animated video to give you an overview on what we will discuss with CARE and more information on research.
Have you ever wondered how scientists find cures for illnesses, discover ways to prevent diseases, and create technologies to improve people's lives? All of our scientific innovations came from research, the process by which we ask questions, perform experiments, and find solutions to the world's problems. Scientific research in the US has led to incredible advances in medicine, but there remains one major limitation. It lacks representation from people with diverse racial and ethnic backgrounds, especially Asian Americans and Pacific Islanders. Humans are incredibly diverse. We have many differences in genetics, upbringing, environments we live in, and cultural backgrounds. These factors all impact whether people can access and how they respond to treatments. When researchers are unable to ensure that every group from every context is properly represented in their research, the results can be skewed towards one or two groups and may not apply to everyone. Currently, Asian Americans and Pacific Islanders are among the least represented groups in scientific research. In fact, research projects that focus on this group account for less than 1% of research supported by the National Institute of Health. But that can change with your help. If you are Asian American or Pacific Islander, age 18 or older, please sign up for the CARE registry. CARE stands for the Collaborative Approach for Asian Americans and Pacific Islanders in Research and Education. This is a research registry created just for adult Asian Americans and Pacific Islanders. Signing up for CARE is free, it is confidential, and you can withdraw at any time. When you sign up, you may be contacted by a researcher about a new research project. What it means to you and what happens if you agree to be part of their study. You can enroll or decline to participate. It's up to you. There are many research questions that you, your family, and your community can help answer when participating in research. For example, how much physical activity do Asian Americans and Pacific Islanders need to do to help prevent memory loss in their lifetime? And how do family members take care of their loved ones who have memory loss or disability? And what kinds of resources do caregivers need to stay healthy themselves? These vital questions cannot be answered without participation from Asian American and Pacific Islander adults from all walks of life who represent a variety of education levels, occupations, and gender identity. By enrolling in CARE and participating in research, you will help ensure that the next generation of innovations can benefit Asian Americans and Pacific Islanders, including your children and grandchildren.
Okay, great. So moving on, I'd also like to review Alzheimer's disease, related dementia, ADRD, and caregiving. So Alzheimer's disease, AD, is a degenerative brain disease and most common form of dementia. Dementia is actually a general term for the decline in mental ability, severe enough to interfere with daily life, and is usually very debilitating and burdensome to those affected. Memory loss is an example of a symptom of dementia. It's a very common symptom, actually. So dementia is not a specific disease, but it's an overall term that describes a group of symptoms. Caregiving can be defined as attending to another individual's needs, often includes assistance with one or more activities of daily living, including bathing, dressing, and so on. These facts regarding ADRD. Alzheimer's disease is the only top 10 cause of death in the United States with no known prevention, cure, or treatment. It's also the 4th leading cause of death in California versus the 6th leading cause of death in the entire United States. Recent estimates have found that Alzheimer's disease may actually be the third leading cause of death, just behind heart disease and cancer as a cause of death for older people. One in three persons aged 65 years and older will die from Alzheimer's disease and related dementia. And therefore, it's crucial that we work to identify how to best support those affected and those who will be affected. So increasing research is very important in order to support our older population and to find future medical findings to combat Alzheimer's disease and related dementia. So for Filipino Americans and Alzheimer's disease and related dementia, it's been found to be very prevalent among this population. So in a study conducted by Kaiser Permanente, Northern California, these researchers found that among the 3 largest Asian subgroups, Filipino Americans had the highest rate of dementia incidence. They also found that dementia risk was approximately 20% higher among Filipino Americans when compared to Chinese Americans. So this is extremely concerning, especially since there is very little data, including the Asian American population, and even less data focusing on Filipinos and Filipino Americans, when it has been found that dementia is extremely prevalent for this population. Existing research on dementia for Asian Americans as a whole usually involves ignoring cultural backgrounds and grouping all Asians into one group, or have only focused on researching Japanese Americans. Again, this is extremely concerning since Filipinos have different foods, immigration patterns, dialects, genetic factors, and other differing cultural characteristics that make them different from other Asian American and Pacific Islander groups. So here we have dementia risk reduction. So there are many modifiable risk factors that can contribute to development of dementia later on in life. So actually 40% of these modifiable risk factors can lead to dementia. These risk factors can include diabetes, depression, physical inactivity, hypertension, obesity, poor diet, education, and so on. On the left, we have a figure showing the percentage of reduction in dementia prevalence if these risk factors are eliminated. So as you can see, that some of these risk factors can begin early on in life, to midlife, and later on life. But it's important to note that there are also many other risk factors that are currently unknown, and more research is needed in order to determine how someone can avoid these risks and aid in the prevention of dementia and aid in the prevention of dementia development. So with dementia comes caregiving. So with dementia caregivers provide valuable care, but are oftentimes hidden patients. These caregivers oftentimes are providing more care than what they're being paid for, and are many times paying out of pocket or having to balance care and work. And this can lead to financial stress and emotional stress for these caregivers. So in 2019, ADRD caregivers provided an estimate of 18.6 billion hours of unpaid care. This was a contribution to the United States valued at $244 billion. It's also been found that 48% of those provide help for adults who have Alzheimer's disease and related dementia. 2/3 of these caregivers are women, 1/3 of these caregivers are daughters, and 41% of these caregivers have a household income of $50,000 or less. So many times these caregivers are low income and have to deal with financial stress of providing this care. And many times it's also within these family networks, so can lead to a lot of exhaustion and burnout. 60% of ADRD caregivers rated their stress as high or very high, and 1/3 reported symptoms of depression. So again, caregiving can be very exhausting and lead to burnout, which is why it's crucial that we acknowledge that caregivers have needs, and we need to identify how to support them through research to learn how to help them. So Filipinos are a very family-oriented culture. Caregiving is a very common aspect to the Filipino culture. It has been found that caring for older family members is a responsibility and expectation, and they are 1/3 less likely to be institutionalized, meaning they're less likely to put their older family members in nursing homes and other assisted facilities. Traditional Filipino families are also less likely to hire professional caregivers and seek supportive services, again, really keeping it within the family network for caring for their elderly family members. It's also very common for them to seek medical advice within their family members who are professional healthcare providers. And it's very important to note that Filipinos have been found to believe that it's a responsibility and expectation. So caregiving, again, is very common in the Filipino culture. which is why it's so important that we help have more research in order to determine how to support these Filipino caregivers and prevent and reduce stress that they may face from the caregiving that they're providing. So Filipino Americans in the United States is a very big growing population. According to the American Community Survey estimates, there's approximately 2.9 million Filipinos in the United States. A large portion of these Filipinos are in California. Around 1.3 million Filipinos live in California, and they are the largest Asian subgroup in California. Filipinos are actually the third largest growing Asian American group in the United States, just behind Chinese Americans, Asian Indians, and there are some key health issues that have been found for this population ranging 65 years and older. These key issues, health issues include cardiovascular disease, malignancy, stroke, chronic lower respiratory disease and asthma, diabetes, but data regarding Alzheimer's disease and related dementia is extremely limited. However, we have found for the research that does exist that Alzheimer's disease and related dementia, there is a high prevalency, but again, research is very limited. We'd also like to acknowledge that there's been a very big impact from COVID-19 on our Filipino nurses. So in the United States, 1 out of 4 Filipinos are frontline healthcare workers. In California, 1 in 5 registered nurses are Filipino. And in New York, 34.4% of Filipinos are in the healthcare industry. So Filipinos play a significant part to our healthcare system in the United States and have been greatly impacted from the COVID-19 pandemic. They have had a higher number of deaths compared to other nurses. And of course, they've been impacted by facing exhaustion, being overworked, and also facing burnout. However, there is no health interventions to support the Filipino community and these Filipino workers who have been providing care in our healthcare system. It's so important that we support research in order to find more data on how to protect our Filipino workforce and how to protect our community. So there are many disparities in research participation for the general AA and HPI community and Filipinos. Current clinical research projects focusing on Asian Americans, Native Hawaiians, and Pacific Islander participants funded by the National Institutes of Health between the years of 1992 to 2018 only comprise 0.17% of the total NIH budget. This was less than 1%. So only 0.17% of the total NIH budget encompass participants with AA and HPI participants, meaning that an even smaller percentage of this 0.17% focused on Filipinos. This is extremely concerning since, again, AA and HPI are the fastest growing racial population in the United States, but they experience significant health disparities and underrepresentation. So basically, their needs aren't being met and represented in research and other policies in this country. And this is why CARE has been established. The purpose of CARE is to address this underrepresentation by creating a research registry of only AA and HPI adults and to connect them with potential research to participate in. We focus on various health topics ranging from ADRD, aging, caregiver-related research, and other health issues that affect the lifespan of AA and HPI. Our goal is to pave the way for meaningful inclusion of AA and HPI in research. We work to address this gap and reduce disparities in research, involving many health topics across the lifespan of AA and HPI. We do this through implementing culturally appropriate and innovative recruitment strategies with our community partners to enroll over 10,000 AA and HPI into a research registry. We aim to do this to give an opportunity and to amplify the voices of the community through the enrollment of CARE. As I touched on before, CARE's theme is health across the lifespan. We chose this topic, this theme, to encompass a family and community orientation focus. As we know that Asian Americans, Native Hawaiians, Pacific Islanders, and especially Filipinos have the collectivist culture, meaning that family and community is a priority. We also wanted to represent that caregivers can be as young as 18 years old, and that there are many protective and risk factors that can begin early on in life, midlife, and later on in life that can affect our health and cognition. Hence why we include people 18 years and older. So CARE is a collaborative effort between multiple community and academic partners. As you can see on this slide, at the heart of CARE is our Community Advisory Board, where we have UCSF, UC California, San Francisco, UC Davis, UC Irvine, ICANN, the National Children's Assistant Network, NAPCA, the National Asian Pacific Center on Aging. I'd also like to highlight our numerous CARE community partners that represent diverse Asian American, Native Hawaiian, Pacific Islander cultures, languages within California and across the nation. They also represent diverse agencies that work directly with the community. It is a priority of CARE to establish these partnerships in order to build trust with the community and also incorporate their insights in our goals. We work with the collaborative approach for Asian Americans, Native Hawaiians, Pacific Islanders, research and education. I would now like to move on to our next speaker, Dr. Joyce Javier.
Thank you, Micah, for that overview and inviting me to speak. So I have the pleasure of being one of the Community Advisory Board members for CARE, and I'm very excited to speak to you today about an example of what can happen if Filipinos engage in research. So I come to you today as a Filipino pediatrician, as well as a mother, a granddaughter, a daughter, as well as a researcher. And my team is called the Filipino Family Health Initiative. And for over a decade, we are a team of multidisciplinary researchers ranging from psychology, occupational health, pediatrics, and we also have churches, schools, parents, grandparents who are part of our initiative. In addition, we have many community partners. Next slide. We also have many interns who have volunteered many hours of their time, who are now gone on to the fields of medicine and nursing. And I really love this quote: "When you go up, always reach back." This is by Anihan from one of my colleagues. And in my career, I was very fortunate to have many mentors in the Filipino community who helped me along the way. So I've always wanted to pay this forward. Next slide. Our initiative would also not be possible without the over 500 Filipinos who have participated in our research over almost 20 years now, including over 200 Filipino families who have done our evidence-based parenting workshops, which I'll describe in the next slides. I think it's really important for me to share how I got to this research. I love this quote by the Filipino hero, Jose Rizal: "He who does not know how to look back at where he came from will never get to his destination." And this means a lot, especially now because it's Filipino American History Month. Next slide. So, while I was in college as an undergrad at UCLA, I took my first course on Filipino American history, and I learned about, our history here in the US, and also kind of the history of colonialism in the Philippines. Next slide. I grew up in historic Filipino town, and my parents are from Agoo La Union and Bacoor, Cavite. This is a picture of my mom's side in Agoo. My mother is the one with the white bow, and she was one of 5 children to my grandparents. My lolo fought in World War II alongside the United States against the Japanese, and they were able to lift themselves out of poverty. Growing up, they, it was emphasized to just listen and obey. Children were not really expected to, voice their opinions. After all, they were trying to just survive. Again, they were able to lift themselves out of poverty, and all of my aunts and uncles and my mom were able to graduate from college. 4 of them became nurses, and my mom became a teacher. Next slide. Growing up, I was born here in LA, and my Lola came to help raise us while my parents both worked full-time. Lola taught us the importance of respecting our elders, and also showed her love through our stomachs, always asking, "Did you eat yet?" Next slide. She also taught us the importance of family. When I moved to Northern California for my pediatrics training, she would stay with me for months at a time when I became a mother. Next slide. At the age of 92, Lola passed away from cancer, multiple myeloma. I still remember that early January morning before she passed on. I wanted to really tell her, "Lola, I love you. Thank you for all you've done for my family and myself. And I'm sorry if I wasn't always there for you to take you to your appointments and be there for you, since I was a working mom myself and had a full-time job." Unfortunately, those words did not come out. Next slide. Growing up, we didn't really say those words, and it was confusing watching television with like these American families, expressing their feelings and having family meetings and having communication. And now I understand that my family showed their love in different ways, working, more than 2 jobs sometimes to make sure we had the best education, leaving their lives in the Philippines to immigrate here. And also they were encouraged to not teach us Tagalog so that we could fit in and assimilate. So in a sense, they had to kind of give up their culture and their roots so that we could survive here. I also saw other teens in my community growing up, being affected by, drugs and teen pregnancy, suicide and cutting. So I became a pediatrician and a researcher to try to address these issues and give back to the community that raised me. Next slide. And I think what was happening is that the youth, when they're seeing what's on TV or what's happening in their friends, they might have that impression that, oh, maybe I am not being seen and being visible. So I wanted to kind of bring a common understanding, because I think that's a huge misunderstanding that sometimes happens among Filipino youth growing up here in the US. Next slide. And so first I had to look at the data. And so one of my first studies was to look at, are there health disparities affecting children in the Filipino community? And I found that the things that I described in our community were not just happening where I grew up, but also among many Filipino youth in the US. Next slide. One of the issues that we discovered was that suicide is a very, very troubling issue that's affecting Filipino adolescents. In this study, they found that Filipinos had the highest rates of suicide ideation. Next slide. We were also approached by schools in the Bay Area, and they shared similar statistics where Filipino middle schoolers had the highest rates of suicide ideation in the past year. Next slide. And so what our community did was ask the community, what are the mental health needs of Filipino youth and how can we prevent it? And we asked church leaders, teachers, mental health providers. We asked the teenagers, we asked parents and grandparents these two questions, and their collective answer was to not wait until the adolescent years, but to focus on the school age years and try to see if we can implement parent workshops during those years to prevent all of these risky behaviors during adolescence. Next slide. And we did this so that we could try to promote these factors, 7 factors that have been shown by research to, if a child can say yes to these items, then when they're an adult, they're going to be more likely to have healthier relationships and less likely to have mental health issues. Next slide. And so I just want to show this video that summarizes our program that was developed for us and by us. And this was actually funded by the National Institute of Health. And so when you think about that less than 1% research funding, that some of that funding went towards this video. So we can play it now. I think the volume is not on.
And a 6-year-old boy.
When I first enrolled in the
Thank you.
I'm from Bulacan, Philippines. I came here 7 years ago. I'm a mother of 2 children, a 9-year-old girl and a 6-year-old boy.
When I first enrolled in the Incredible Years, I really wasn't expecting much. I was thinking probably everything was already okay. So it more curiosity than actually thinking that I had a need. And so when I was finally in there, that's when I realized that there's so many things that you could actually learn in that program.
I never heard my mom praise me. Unfortunately, I think the culture in the Philippines is very different here. Okay, I want to raise my kids the way my parents raised me. But somehow there are things that my parents raised me that doesn't agree with the culture in the United States.
This type of education would be able to help our children have better relationships with their parents, become better people in the future, and therefore is a good investment for the future.
Filipinos are the second largest immigrant population in the United States, but there are very few programs that have addressed our community's specific needs. In my research, I have found that Filipino youth living in the United States have higher rates of behavioral problems compared to other Asian subgroups. A survey by the Center for Disease Control found that 45.6% of Filipina high school students said they had seriously considered attempting suicide. Half of those who thought about suicide actually attempted suicide at least once during the past year, the highest percentage of any ethnic group in the study. The Incredible Years is a 14-week workshop led by trained professionals such as myself. In these workshops, we will be going over proven strategies to prevent and handle misbehavior. We will also discuss tools on how parents can promote their child's self-confidence and encourage their child's ability to solve problems and express their feelings.
So my name is Dean Coffey, and I'm a licensed psychologist and have been working with the Incredible Years for the last 12 years or so. And the reason why I like working with the Incredible Years is it's so effective in preventing and reducing child conduct problems. And we know that about 1 in 5 children will develop behavioral disorder at some time in their lifetime. And so by doing the Incredible Years program and doing the special time with their kids, parents are making an investment in their child's future.
This program is really promising because they have a culturally based strategies to help Filipino parents to get their own parenting styles that are based on our culture, and at the same time, we can devise our own strategies.
My own personal relationship with my father, I mean, I love him, absolutely love him. He's an excellent father. But at the same time, I was never really able to be close to him where I can actually tell things. And right now, I believe that if we do things a different way, if we encourage our children in a different way, and all of these things are being taught there in the Incredible Years program, we will be able to achieve a certain closeness. But at the same time, our children will still be very obedient, very great kids.
I was able to communicate with my daughter well through everyday interactions.
You're going to see how your children would be able to flourish much more by implementing simple techniques, simple things that you'd learn from the program.
We're more closer to each other as a family. There's harmony, there's peace. Children listen to me more.
Giving compliment or praising my son is very effective. In the Incredible Years, it's not just, developing your academic skills, preparing your kids to do that, but basically the emotional side, the social side is also wrapped there, where you are able to have a relationship as parent, daughter, like friends forever. And the bonding is very, very important because that balances everything. Your intellectual, your emotional, your spiritual, and social, all wrapped into one and making you a healthy family.
Thank you, Micah, for sharing that. So, in conclusion, I just want to share, right before my Bola passed away, the question I did ask her was, Bola, are you proud of me? And she said yes. And that meant the world to me because it wasn't because of my achievements, but it was because of love. And so I've learned so much from the parents who've done our workshops, and I'm really excited to see if we get more Filipino families to do care, how that's going to impact our communities even more. I have two older relatives who passed away from dementia and many family members who helped take care of them. So I'm very excited about care. Thank you for your attention. And I'll write in the chat, some more information. Thank you. Actually, while she's pulling it up, we are doing workshops in the Philippines now and the rest of the United States, so you can email me. And I'd like to pass it on to Araceli.
Oh, thank you, Joyce. That was a great story. I'd like to share that with my family as well. So, good morning, everyone. I'm Araceli Antonio, and I'm a retired nurse, as Micah mentioned, and I work primarily in long-term care. I retired after working 50 years in nursing. So what I would like to do today is to just share my professional experience with care of residents with dementia. It started in 1975 at Mission Terrace Hospital. You probably don't even know this hospital because it doesn't exist anymore. I think it changed to San Francisco Psychiatric Hospital years ago, and I don't even know if it exists now. But anyway, it was my first experience with patients with Alzheimer's disease was in that hospital. And I did not know anything about Alzheimer's. I had a 35-year-old patient with a diagnosis of Alzheimer's disease. I have not encountered this diagnosis before, so I asked my medical director what it was. He said it was pre-senile dementia. The patient showed the characteristics of what we now know as later stage of dementia. Although she was still walking, she really needed total care. I remembered her pacing continuously and gradually slowed down and not eating as much. And she died after 4 months later. Now, Dr. Alois Alzheimer was a German psychiatrist and neuropathologist and is credited with identifying the first published case of presenile dementia. which would later be identified as Alzheimer's disease. And in 1978, I was the director of nursing services at Hillhaven 19th Avenue. This was a place where the interdisciplinary team unknowingly created a dementia unit. And let me explain. The facility, Hillhaven 19th Avenue, has 3 floors. And we had, the first floor was more for, for the residents. It's a combination of residents who are cognitively impaired and also those who are has cognitive, who's alert and oriented. So, and then we have the second floor, which is more like our subacute care unit. And we had the residents who needed skilled nursing and skilled rehab services. The third floor was also a combination of both the alert and confused patients. What happened during that time was on the first floor, we had the residents who were alert and oriented were very, were angry at the confused patients. They were always having altercation. And most of the altercation was verbal, but occasionally there would be some physical altercation. And so our team, the interdisciplinary team, which consisted of the nursing director, the staff development coordinator, social worker, activity director, and physical therapist, we all decided to do something about it. So we met, and actually it was the activity director who suggested that we should probably move all the confused patients to the third floor. So we talk about the pros and cons of this, and then we were able to agree that it would be better for the confused patients to go to the third floor. So after getting the approval of administration and also the family members, we just did that. And after the move, we found out that the first floor became quiet because most of the people, most of the residents in the first floor are already alert and oriented. The confused patients went to the third floor. So when we visited the third floor, it was actually very, it was like a happy place. The confused patients, they were participating in unique activities. They love music, and nobody was bothering them. The alert and oriented, there were no alert and oriented patients that would be talking back at them or telling them, to shut up or disturbing them. So that was a good move. And it was, so that was what we called, or I called, the unknowingly created dementia unit. And then in 1980, I became a nursing consultant for Hillhaven. And the vice president of operation at that time decided to have a dementia unit, create a dementia unit in one of the hospitals, which was the Pine Towers Convalescent Hospital. And because of my experience in at the Hillhaven 19th Avenue, I was able to help develop that unit. It was very interesting that the vice president of operations, who was not a nurse, was very interested in, in working with me, develop policies and procedures for the unit. It's very unusual to have administration, do this. And then we asked Dr. Barbascia, who was a UCSF physician, to help us with the training program. We also had a 36-hour, what do you call this now? Nancy May's 36-hour day family guide for caring for people with Alzheimer's as a resource. And if I remember correctly, we even had asked, I think, Nancy Mays to be our consultant for our training program. So the unit was about 24 bed, and it's not, it was on the third floor. It wasn't an ideal unit because of the physical plant. but it's good for a specialized program, because then you have all, you know, you got all the residents with dementia in one unit, and then you've got trained nursing assistants and other healthcare professionals to help the residents in that unit. And then in 2002, 2008, I was employed as the Director of Health Services at Channing House. Now, Channing House is a continuing care retirement community. It has 3 levels of care. It has independent living, assisted living, and skilled nursing. And there was a plan for a special care unit for residents with dementia. The board decided that you know, since majority of the CCRCs and other facilities have memory unit, so they felt that we should have one as well. So we had a long discussion whether the unit, whether we should have a special care unit, or we can have a specialized program that would be integrated with our assisted living residents. And you know, our medical director, the activity director, and myself, we're leaning towards integrated with assisted living. And the rationale was, in our facility, in the Channing House facility, all the residents that were admitted to Channing House go to the independent living first. So they're basically, you know, they can live independently in their unit, and then as they develop some health problems, they go to the assisted living, and if they need more care, skilled care, then they go to the skilled nursing. We did not admit anybody from outside to go to the assisted living or to the skilled nursing. So in essence, you know, when the residents go to the independent living, they're almost like a family, because you know, we have common areas for meals. They have you know, educational programs that are being offered in the unit, I mean in the facility, and then we also have church services. So basically, all the residents in the independent living know each other. So it's like a family. If one of their neighbors is not feeling well, believe me, they would let the nursing staff know. So if a resident has started having memory problems and they go to the assisted living, the independent living residents who had become their family, basically, quote unquote family, visit them, and they, you know, they still interact with them. So we thought that even though the confused patient, the patient with dementia, is in our assisted living, they would be the residents in the independent living would be comfortable visiting them, because they're like their family. Whereas if you have a separate unit, there will not be that interaction with residents who are not confused. So they're all confused patients in one unit, and we didn't feel that was good for the residents. I think they would deteriorate faster. That was our opinion. You know, like my medical director, we're all together in this, and we have found that, you know, people that were in our assisted living who are confused, and if we had one of the programs what we did was a volleyball. Can you imagine having volleyball in a unit? But our residents in independent living would go to the assisted living and play volleyball with the confused residents. I mean, it was like, because they're like family. So anyway, that was our bias towards having an integrated program with the assisted living residents. Unfortunately, I left Channing House before they decided on what to do. I haven't really talked to them since then because of pandemic. So I'm hoping they look at the integrated program as as their program rather than having a special care unit. So those are my experiences with dementia. And I have two wishes actually. Since pandemic, I've been living alone for the past 2 years. Well, not just past 2 years, but since my husband passed away. But I had more understanding, I guess, of how our government works, how our healthcare system works. And I thought about, one of my wishes would be to have a research project. And maybe both Joyce and Jessica can help with this. I'm thinking that if a brain scan can be done on all people who are 30 years old, and then you do it again after 10 years and compare it. Now, to me, why are we doing these brain studies, do autopsies? You do it when they're dead. I mean, that's not good. We need to know before, when we're healthy. So, I believe that the only reason we don't do brain scan on younger folks is because of money. It's always money, because I don't know how much brain scan costs. Can you just think? I used to work at Kaiser when we were doing EKG every year. It's called the multiphasic. I don't know if you folks, this was years ago, 40 years ago, you probably don't know this. But we had a multiphasic program that we did EKG every year. And then they removed that program. I guess it became very expensive. So think about this. If you have a brain scan at 30 years, and then repeat it in 10 years, when you're 40, you compare it and see if there's some abnormality between the two. You would know that. I mean, Jessica and Joyce, you would know, as a doctor, you probably would know there would be a difference. So if you find that there's some difference now, then you do something. You do something about it. And I'm sure there are some research studies that would help us figure out how those, how the brain cells can, what do you call this, can revive. If there's some brain cells that are dead already, maybe there's something that can be done. So that's my wish, that maybe the government would pay for those. And the insurance company should think about, doing some preventive measures rather than doing the cure or treatment. Let's do preventive measures more. And then my second wish is, I love the continuing care retirement community. When I worked at Channing House, that was my first time I was in long-term care for many years. It was my first time to know what CCRC is. And it is a very good facility for people who are over 65, especially those who are living alone, because it's a community. So my other wish is for the government, again, to help develop these community care retirement communities in geographical areas. And I wish we will have one for Filipinos, so that, it is a community, to be a community. It's like having, as I said earlier, it is a community, but they become a family. And then you promote independence. You can maintain independence of the residents that will be living there. You can promote their, you can be assured of their physical, mental, and spiritual health. So those are my two wishes. So I hope, Joyce and Jessica can help us with the brain thing. And if there's anybody there who knows more about development of facilities, we should do that for Filipinos. Anyway, thank you very much.
Right. Yeah. Thank you, Ate Araceli. Hi, it's good to see you all. I'm really grateful for the opportunity to speak with you today. Just a little background. My family's from Pangasinan and from Malabon. I was born and raised here in the Bay Area in San Jose. And it really was some of my family's experiences earlier just with stroke and with dementia that really impacted my decision to study the brain and neurology. So I'll just take a couple of minutes to share a bit from my perspective as a Filipino neurologist, why I think it's important for our community to participate, be represented in dementia research, and also why it's hard to diagnose dementia, as Araceli was saying, when it's later in life, right, in our population. So how our research is partnering with the care registry, how we're starting to address some of these reasons. So next slide. So normally if someone is coming to our clinic and they say that they're having memory problems, there are a few things we can do to try to figure out why someone is having the memory problems. And there's a lot to even just talk about whether or not the community even feels comfortable, right, going to a memory clinic in the first place. Sometimes we think, oh, okay, it's maybe just a part of being older. But also I think sometimes we don't always like people outside of the family to know if we're having any kind of memory trouble. But if someone does come to the clinic, there are some things we can do. So we look at blood tests. We might look at brain imaging to look for signs of atrophy or volume loss. So in the bottom picture, you can see a healthy brain on the left, and then what it might look like on the right if someone is starting to develop Alzheimer's. And then the other thing we can do is we do pen and paper tests. And so this might be something like, okay, please draw a clock and then put the hands at a certain time. And then next slide. But the problem is with the tests, they're really made for English speakers and for people who grew up in the US culture. So that's a bit of a problem because like this is an example, right? In Tagalog, there's no word for beaver. So one of my patients, she called this a rat. And I was thinking to myself, okay, is that close enough or is that wrong? So I just show this to illustrate, right? If someone speaks another language besides English, or maybe their proficiency isn't so high in English and they get this question wrong, is it because they have dementia? Or is it that there's a problem with the test, right? And then it's a bit unfair because you're asking for a word that doesn't really exist in the person's language. So I think we do need better tests that are culturally appropriate for different populations, that use the vocabulary, the structure of different languages. And this is something that we're trying to address. So we have a study that's funded by the NIH. And as we mentioned before, one of the few that's really focused on the AAPI population. And we're starting to enroll Tagalog speakers to help us test the test, right? Figure out how Filipino adults would normally perform on these tests. And then next slide. And so in some of the other tests, sometimes the goal it's for someone to name things as quickly as they can. And that's supposed to tell if someone is developing dementia or not. But if you're bilingual, you have two words in your mind for this object, even if it's very common, like an apple. So this is example from English and Spanish. So it takes extra time to choose the word if you're bilingual, and then you get slower on the testing. And then when they grade it, though, it doesn't really take into account that maybe you're bilingual. So then you get a lower score, and then it might make it seem like you have dementia, but really maybe you're being misdiagnosed because the norms aren't really taking into account those language experiences. And it could be the opposite too, right? The person who's giving the test thinks that, oh, it's the only reason they're having trouble is because they're bilingual. But actually, they're missing that they do actually have dementia. So this is another piece of the research, just trying to figure out how being bilingual impacts the score on some of these tests. Okay, and then maybe I'll just skip the next couple of slides, which show just some of the things we're finding in our research. And I'll just go to the summary. So, just to echo what you're hearing from our other speakers as well. On the next slide, I just think, I hope that we're showing a little bit that it is important to have participation and representation from the Filipino community. And, this is from my perspective, working in dementia research. I really do think that participation can be really valuable in improving diagnosis and care, and for our community, for our elders, for our own family members, if they were to ever unfortunately need this type of care. And I do think we can do a better job with diagnosis. And you know, I do think our voices are really important. I think that coming together in participation is a way for us to learn from each other, to help us take better care of each other and for future generations as well. So thank you for your attention. I'll pass it back to Micah.
Okay, thank you so much, Jessica. Let's see. Just a reminder that Care Registry is now enrolling. We're continuously enrolling participants. So as of September 25th, last month, our Care reached our enrollment of 94% of our 10,000 goal. So we have enrolled 9,360 Asian Americans, Native Hawaiians, and Pacific Islanders. But unfortunately, out of this number, only 4%.
4% of care.
Yeah, only 4% of care is Filipino. This is very unfortunate because we really want to increase Filipino representation and really amplify the voices and support Filipino needs in future medical findings. So here we have our eligibility criteria. So you must meet this eligibility criteria in order to participate. So first, you must identify as Asian, Asian American, or Pacific Islander. You must be at least 18 years old or older, have the ability to speak in English, Mandarin, Cantonese, Korean, Vietnamese, Hindi, or Samoan, or read in English, Simplified Chinese, Traditional Chinese, Korean, Vietnamese, or Samoan. We're also currently working on adding Tagalog and Ilocano into our survey, so that will be added very soon. And of course, you must have interest in participating in potential research. Again, I would like to highlight that by enrolling, you are not required to participate in anything. It just gives you the opportunity to potentially be contacted. So some of the enrollment questions that you might see are some questions asking about your health conditions. Examples are neurological disease, symptoms of Alzheimer's disease and heart disease, cancer, maybe mood-related issues. Also questions about health behaviors such as smoking, physical activity, diet, and so forth. And questions about your socio-demographic background, and questions about caregiving experiences if applicable to you. So how can you enroll? You can enroll by visiting our website. Our website is here highlighted in blue, careregistry.ucsf.edu. You can enroll by visiting the Enroll and Care tab. The survey takes about 10 to 15 minutes to complete. And again, questions about your social demographic background, general health questions, and caregiving questions. And upon completion, you'll also have the option to receive a $10 gift card, just as a token of our appreciation for participating in care. So that concludes our presentation, and thank you all for being here today. I'd like to provide you all with our contact information, so feel free to screenshot, take a picture. We have our information of our principal investigator if you would like to further connect, as well as our email address, our phone number, and our website. So that concludes our presentation. Thank you all for being here today.